Welcome to Pharmacology Deep Dive. Today we're covering beta blockers, one of the most commonly prescribed drug classes in clinical practice. This video is designed for healthcare students and professionals. Beta blockers are one of the most commonly prescribed drug classes you will encounter in clinical practice, and they are heavily tested on board exams. By the end of this video, you will understand how they work, why they cause the side effects they do, which patients should never receive them, and the specific drugs that are high yield on exams and clinical decision-making. Before we dive in, an important thing to remember: every generic beta blocker name ends in LOL: metoprolol, propranolol, atenolol, carvedilol, labetalol. All of them. Let's understand what beta receptors do. Your sympathetic nervous system, the fight or flight system, releases norepinephrine and epinephrine. These catecholamines bind to beta-adrenergic receptors and rev up the body. Beta blockers sit on these receptor sites and block norepinephrine and epinephrine from binding. The result? The sympathetic response is blunted. The heart slows down, contractility decreases, blood pressure drops, and the heart's oxygen demand goes down. That is why beta blockers are used for hypertension, heart failure, angina, arrhythmias, and post-myocardial infarction care. There are two beta receptors you need to know. Beta-1 receptors are primarily located in the heart and the kidneys. Remember, you have one heart, so beta-1 equals heart. When beta-1 receptors are stimulated, heart rate increases, contractility increases, conduction speed through the AV node increases, and the kidneys release more renin, which raises blood pressure through the renin-angiotensin-aldosterone system. Beta-2 receptors are primarily in the lungs, GI tract, and vascular smooth muscle. Remember, you have two lungs, so beta-2 equals lungs. When beta-2 receptors are stimulated, the bronchioles dilate, the liver performs glycogenolysis, releasing stored glucose into the blood, and peripheral blood vessels relax. Selective, cardioselective beta blockers block mainly beta-1 receptors. They primarily affect the heart and spare the lungs. Examples: metoprolol, atenolol, bisoprolol, esmolol, nebivolol. Non-selective beta blockers block both beta-1 and beta-2 receptors. They affect the heart and the lungs, GI tract, and peripheral vasculature. Examples: propranolol, nadolol, sotalol. Carvedilol and labetalol are also non-selective, but they are unique because they additionally block alpha-1 receptors, which causes vasodilation. The beauty of pharmacology is that side effects are predictable once you understand the mechanism. Every major beta blocker side effect traces directly back to blocking beta-1 or beta-2 receptors. Bradycardia: you are slowing the heart. If the heart rate drops below 60 beats per minute, hold the dose and notify the provider. This is one of the most common clinical interventions with this drug class. Hypotension: decreased cardiac output means lower blood pressure. Hold if systolic BP falls below 100 mm mercury. Counsel patients to rise slowly to avoid orthostatic hypotension. Fatigue and exercise intolerance: the heart cannot mount a normal response to increased demand because you have blocked the receptor that speeds it up. Masking of hypoglycemia: this is a critical board exam point. When blood sugar drops, the body normally triggers tachycardia as a warning sign. Beta blockers prevent that tachycardia, so the patient may not realize they are hypoglycemic until more dangerous symptoms appear: confusion, seizures, or loss of consciousness. However, other symptoms of hypoglycemia like diaphoresis and hunger are still present because sweating in hypoglycemia is mediated by cholinergic sympathetic fibers, not beta receptors. Counsel diabetic patients to watch for those signs instead of relying on heart rate changes. From blocking beta-2. Bronchospasm: beta-2 receptors keep bronchioles open. Block them and you get bronchoconstriction. This is mainly a concern with non-selective beta blockers. Patients with asthma should not receive non-selective beta blockers. Patients with COPD should use beta blockers only with caution, and if needed, a cardioselective agent is preferred. Cold extremities. Blocking beta-2 receptors on peripheral blood vessels prevents vasodilation, reducing blood flow to the hands and feet. Other important side effects. CNS effects. Propranolol is lipophilic and crosses the blood-brain barrier readily. It can cause depression, vivid dreams, and insomnia. Hydrophilic agents like atenolol are less likely to cause these effects. Sexual dysfunction. Particularly erectile dysfunction in males, this is a frequent reason patients discontinue the medication without informing their provider. Rebound effect. If a patient stops a beta blocker abruptly, the body's upregulated receptors are suddenly unblocked, which can cause rebound tachycardia, hypertension, and even angina or myocardial infarction. This carries a black box warning. Always taper beta blockers over 1 to 2 weeks. Never stop abruptly. These are the patients who should not receive beta blockers. Severe bradycardia, heart rate below 60 BPM, since you would make it worse. Second or third degree AV block without a pacemaker. Beta blockers slow AV conduction further and could cause complete heart block. Decompensated, acute heart failure. The heart is already failing acutely and cannot tolerate further reduction in contractility. However, and this is a common exam trap, stable chronic heart failure is actually an indication for certain beta blockers: carvedilol, metoprolol succinate, and bisoprolol. These three have been shown in large clinical trials to reduce mortality in chronic heart failure with reduced ejection fraction. Asthma. Non-selective beta blockers are contraindicated. Even selective agents should be used cautiously. Cocaine-induced chest pain. This is a classic exam question. In cocaine toxicity, blocking beta receptors can lead to unopposed alpha-adrenergic stimulation, which can worsen coronary vasospasm. Use benzodiazepines and nitroglycerin instead. This is the most commonly prescribed beta blocker in clinical practice. It comes in 2 formulations: metoprolol tartrate, immediate release, given twice daily, and metoprolol succinate, extended release, given once daily. The succinate form is the one approved for chronic heart failure. This distinction is tested on board exams. Clinical Pearl. Assess heart rate and blood pressure before every dose. Atenolol is water-soluble, meaning it does not cross the blood-brain barrier as readily, so it causes fewer CNS side effects like depression or nightmares. It is renally excreted, so dose adjustment is needed in patients with kidney impairment. Propranolol is the classic non-selective beta blocker and has the widest range of indications. Because it is highly lipophilic and crosses the blood-brain barrier, it is used for performance anxiety, essential tremor, and migraine prophylaxis. It is also a key drug in managing thyroid storm because it blocks the peripheral effects of excess thyroid hormone, including tachycardia and tremor. Remember, propranolol does not treat the thyroid problem itself, it controls the symptoms while definitive treatment is initiated. Important. Take the immediate release form on an empty stomach. Do not crush extended release formulations. Carvedilol is a combined alpha-1 and non-selective beta blocker. The alpha-1 blockade causes additional vasodilation, which is why orthostatic hypotension is a significant concern. Key clinical point from the FDA prescribing information. Carvedilol must be taken with food. Food slows the rate of absorption and reduces the risk of orthostatic hypotension. It is one of the 3 beta blockers proven to reduce mortality in chronic heart failure with reduced ejection fraction. Carvedilol is also used off-label to prevent esophageal variceal bleeding in patients with portal hypertension due to cirrhosis. Labetalol is the go-to beta blocker for hypertension in pregnancy. It is available in both oral and IV forms, and IV labetalol is commonly used in hypertensive emergencies, including preeclampsia and eclampsia. Clinical Pearl. When giving IV labetalol, keep the patient supine during and for 3 hours after administration to minimize hypotension. Also monitor for neonatal bradycardia, hypotension, and hypoglycemia in newborns exposed near delivery. Esmolol is an ultra-short-acting IV beta blocker with a half-life of about 9 minutes. It is used in acute settings, supraventricular tachycardia, perioperative hypertension, and aortic dissection. Its extremely short duration makes it ideal for critically ill patients because if the patient develops a problem, the drug wears off quickly. Sotalol is unique because it has both beta-blocking properties and Class 3 antiarrhythmic activity. It blocks potassium channels, which prolongs the QT interval. Because of this, sotalol carries a risk of torsades de pointes, a life-threatening arrhythmia. Patients must be monitored on telemetry when initiating sotalol, and you should check the QTc interval regularly. Sotalol is renally excreted, so dose adjustments are needed in renal impairment. Let's go over the 7 points you must know about beta blockers for exams. Number 1. Hold parameters. Always check heart rate and blood pressure before administering a beta blocker. Hold if HR is below 60 or SBP is below 100 and notify the provider. Number 2. Never discontinue abruptly. Stopping suddenly can trigger rebound tachycardia, hypertensive crisis, or acute coronary events. Taper over 1 to 2 weeks. Number 3. Masking hypoglycemia in diabetic patients. A classic exam scenario: a diabetic patient on a beta blocker with an unexplained change in mental status. Think hypoglycemia. Check the blood glucose. Number 4. Asthma and non-selective beta blockers. If the question stem mentions asthma, a non-selective beta blocker is the wrong answer. Number 5. Carvedilol with food. If the question asks which instruction is most important for a patient starting carvedilol, taking it with food is frequently the tested answer. Number 6. Labetalol in pregnancy. If the question involves a pregnant patient with hypertension, labetalol is typically the correct drug choice. Number 7. Heart failure medications. Know that carvedilol, metoprolol succinate, not tartrate, and bisoprolol are the 3 evidence-based beta blockers for chronic heart failure with reduced ejection fraction. Quick board exam scenario. A patient with chronic heart failure and a history of asthma is prescribed a beta blocker. Which drug is most appropriate, cardioselective or non-cardioselective? The answer would be a cardioselective agent like metoprolol succinate or bisoprolol, since non-selective agents like carvedilol would carry a higher risk of bronchospasm. However, always note that even cardioselective agents should be used with caution in asthma patients. Selectivity is dose-dependent and can be lost at higher doses. Let's recap. Beta blockers block beta-adrenergic receptors, reducing heart rate, contractility, and blood pressure. Selective agents target the heart. Non-selective agents also affect the lungs and periphery. The side effects, bradycardia, hypotension, bronchospasm, masked hypoglycemia, all trace back to which receptors you are blocking. For your exams and clinical practice, remember, check vital signs before giving the dose. Never stop abruptly. And know your drug-specific facts like carvedilol with food and labetalol for pregnancy. If this helped you, hit that subscribe button and turn on notifications so you can master your pharmacology. Drop a comment with which drug class you want next. I'll see you in the next one.